Chief of the Medical Division of Kumon Medical Center. I'm very honored to introduce you to Professor Hagen. Professor Jeffrey Hagen is the Chief of the Division of Thoracic Surgery and the Director of the General Surgery Residency Program at Keck School of Medicine of the University of Southern California. He is specialized in the field of general thoracic surgery and robotic surgery. Last year, he told us about Da Vinci. So how many cases this year?
We've done almost 100 this year.
100. So today, Dr. Hagen, Professor Hagen, will talk about with EGAS, enhanced recovery after surgery. Very interesting theme. So please join me in welcoming Professor Hagen.
Thank you very much. It is, again, a pleasure to be here and to have the opportunity to speak to you again. It's always, as I said yesterday, a highlight of my year to come here and meet with all of the interns and members of the medical staff here. And to have an opportunity to talk to you and catch up. So I'm going to talk this evening about advanced recovery after surgery, or as it's called, ARIS systems. The ARIS programs are designed to improve outcomes, to speed recovery and reduce costs associated with surgical care. Most of the initial work in enhanced recovery programs was done in colorectal surgery, but as you will see, it has applications in a wide variety of surgical procedures. And so what we're going to talk about tonight is just what are the important elements of an ARIS program. We'll go through some of the published results to date and discuss how these changes can be implemented into surgical practice. So the goal of enhanced recovery programs is to improve the quality of surgical care. This is something that Americans began to focus on in the early 1990s when managed care came into being. The focus of managed care was on reducing cost, and so there was concern on the part of the American citizens that cost might come to dominate over quality of care. And so it was really a focus during that time period. So the government created this Commission on Consumer Protection and Quality in Healthcare, and they published their results in 1998, and they were looking at processes by which we can define and measure quality in healthcare. And the problem is that when you look at quality in healthcare, there's really very little objective data as to what constitutes quality care. There are very few mandatory databases in the United States that keep track of quality. We have way more information on quality for airlines, restaurants, and cars than we do on something as important as healthcare. So what is quality? The Institute of Medicine defines quality as the degree to which health services for individuals and populations increase the likelihood of desired healthcare outcomes and are consistent with current professional knowledge. In other words, providing patients with appropriate care service in a technically competent manner with good personal and professional skills. The problem is that it's really hard to define good quality. We know what bad quality is. If you give too much care and do unnecessary tests, if you don't provide enough care and you fail to reach the standard of care, or if you do the wrong care and you do poor technique or give a drug that has an interaction with another drug, those are all easy measures of bad quality, but it's really difficult for us to define what good quality is. There are some studies, though, that have looked at quality of care in the United States, and it's not very impressive. This was a literature review of all studies that looked at quality of care and healthcare in the United States. It was 48 studies involving about 500,000 people. And they looked at preventative measures, acute care, medical and surgical, and management of chronic disease. And the most important finding was that there are large gaps between the care that patients should have gotten and the care that they actually get. And overuse is equally common as underuse. Just some examples. In the United States, 1/4 of children don't get all of their recommended immunizations. Half of adults over 65 don't get a flu shot when that's recommended. 54% of women don't get their recommended annual mammograms, and half of adults over 40 don't get screened for colorectal cancer. In acute care, 60% of the patients with a common cold get unnecessary antibiotics. 50% of children who get tubes inserted, myringotomy tubes inserted, it's for inappropriate indications. And 1/3 of all hip fracture patients admitted to the hospital received substandard care. In chronic disease, it's no better. Only 50% of diabetics had an annual eye exam, in spite of the fact that this is the #1 cause of preventable blindness. Less than half of the patients had adequate control of their hypertension. 1 in 6 hysterectomies that were done for inappropriate reasons, and the list goes on. And these are embarrassing numbers for me or for anybody in the United States, because we have the most expensive healthcare system in the world, and this is the type of care that we're providing. When you look at specifically at surgical errors, we're not doing much better. These data from Health Grades in 2004 show that almost 100,000 deaths every year in the United States are attributable to patient safety incidents after surgery. And the most common causes are listed in this table. And not only deaths, but a huge number of morbidity or complications associated with preventable errors in surgery. And most of these, as I said, are completely preventable if we would just apply the level 1 evidence that we have to patient care. The problem is that there are so many randomized trials out there providing us with all kinds of information about how we should care for our patients that we just can't keep up. This is a slide that shows all of the published randomized controlled trials around the world by year since 1964. In 1964, there were 34 randomized trials published. In 2008, when this study was done, it's more than 25,000 published randomized controlled trials. If you break that down by week, it's 500 randomized trials published every week and 100 every day. So it's impossible to keep up. There's no way that any single person can keep up with all of this information. It would be a full-time job to keep up with all of this level 1 evidence. So how do we approach quality? Well, in surgery, historically, we've used case review to reflect on what went wrong, what we might do better the next time. We have M&M conferences, and these types of approaches are good, but they drive quality improvement only on an anecdotal basis. One case at a time. We review what happened, what went wrong, and what we can do next time. In the 1980s, we borrowed the concept of continuous quality improvement from industry to use consensus to identify areas for improvement, but again, this is largely retrospective and analytical in approach. In the 1990s, patient care pathways were introduced to define standardized processes of care, step-by-step instructions of how patients will be cared for. And those were very useful for high-volume procedures like bypass operations and hip replacements, but they are typically unimodal in approach. There's only one specific specialty, one specific outcome that is being addressed in this approach. More recently, the concept of enhanced recovery programs has emerged. And this is a process that was initially described by Kellett, who comes from the Netherlands, in this publication in 1997. And he basically broke down the process of recovery from surgery into these 6 steps: the outpatient clinic, preoperative preparation, surgery and anesthesia, the perioperative event, and then recovery, which was broken down into these 3 phases. And then he defines specific interventions that we can take to speed recovery and reduce complications in each of these steps. And the basic philosophy behind enhanced recovery programs is to apply the best practices from the literature in each of these areas with a goal of maintaining homeostasis and optimizing recovery. In other words, minimizing the stress response to surgery and reducing complications. So this is the list of the sort of evidence-based components of an enhanced recovery program, and we'll touch on most of these through the talk. But basically the hypothesis of enhanced recovery programs is that interventions in multiple areas using a multimodality approach is more likely to be successful than addressing each of these things one at a time. So, where did this concept come from? Well, Kellett, in this paper in 1997, proposed the enhanced recovery program in this, what I would say is a seminal publication on the topic. And he said that despite many advances in anesthesia, surgery, and perioperative care, major surgical procedures are still followed by undesirable complications and consequences, unnecessary pain, complications, and a prolonged recovery. And he further hypothesized that no single technical advance or drug regimen has been shown or is likely to show an elimination in mortality and morbidity after elective surgery. And he said that one common feature of all of major operative procedures is this surgical stress response. And he targets in these enhanced recovery programs things that we can do to reduce that. The surgical stress response evolved in humans as a protective measure to survive injury, but when it's amplified or prolonged, it can be detrimental to the patient's recovery. So to understand the pathogenesis of postoperative morbidity, we have to better understand the components of the stress response and look at ways that we can modify this response to improve outcome. So in this report, he conducted an exhaustive literature review to identify techniques for controlling postoperative dysfunction, reducing stress, and patient pain, and all of this was focused on elective surgery. This is a busy slide, and you don't really need to pay too much attention to the details, but suffice it to say that there's a wide range of areas of intervention, potentially, in terms of risk factors and neurohormonal responses that we can modify to reduce morbidity. So that publication was very interesting, and if you have a chance, you should read it, but it really is just a concept. It was a comprehensive literature review, and there was data supporting each of these individual components, but there was no studies or anything done to show that changing all of these things actually mattered. And in that report, he called for future research on all of these aspects of enhanced recovery programs. But as I'll show you, experience has shown that this proposed approach is actually quite effective. So the first report that looked at an actual series of patients and outcome using this type of approach was by the same group from the Netherlands, published 2 years later. They did 16 open sigmoid colectomies for cancer using this multimodality approach with 9 specific elements from that big picture there, that big figure that I showed you. And this is open surgery, remember, not laparoscopic, and these patients went home on an average of 2 days following surgery, which was really quite amazing. They were up walking for 5 hours on the first day and 10 hours on the second day after surgery. They were on a complete oral diet with bowel function within 2 days, and they had no complications or readmissions. So now it's only 16 patients, but very impressive results for the first application of an enhanced recovery program. So that then was followed up about 5 years later by the same group with this publication in the American Journal of Surgery, which looked at all articles published since their original report on these enhanced recovery programs. Now, they're usually referred to in the literature as accelerated care programs or fast-track surgery, and those are the sort of common terms if you're looking into this literature. And they summarized all of the evidence that's available in the literature on methods of care in non-cardiac elective surgery to look at things that reduced length of stay and improved outcome. And as they had before, they broke this process down into these 3 steps: preoperative, perioperative, and postoperative care. So what are the elements of an enhanced recovery program? First, there's the preoperative period. This involves a routine assessment of comorbid conditions and appropriate interventions to try and reverse those. And those involve cardiac disease, COPD, and diabetes predominantly. Now, this is nothing new to surgeons. We always do this in the clinic. We take a careful history and, if necessary, intervene. And so that in and of itself is not all that exciting. But they've also implemented some other steps in the perioperative period. For example, if there is level 1 evidence, by the way, anything that you see in italics like this font is either a randomized trial or a systematic review. So this is level 1 evidence that if the patient abstains from alcohol for 4 weeks before surgery, perioperative complications are lower. And this is not just for alcoholics, this is for any patient who's having elective surgery. If they avoid alcohol for 4 weeks, they have less complications. They also, in these enhanced recovery programs, introduce patient education regarding the recovery process, which has been shown to modify the patient response and improve outcomes. And this is not new information. This was published in the New England Journal in 1964. It was a randomized controlled trial at Massachusetts General Hospital in 97 patients undergoing elective abdominal surgery. The standard approach was to have a visit with the anesthesiologist, and they'll discuss with you the plans for management of the anesthesia. But in the special care group or the study group, they also talked extensively about where the pain was, what it was going to feel like, how long it would last, reassurance that the pain was normal, and talk about the plans for dealing with the pain. And what they found, nothing else was different about these patients, and what they found is that the total amount of morphine required was half as much in the patients who had just simple explanation about what to expect. And the length of stay was 2.7 days shorter. So spending time talking to your patients and giving them encouragement and instruction about what to expect can by itself have an impact. The next element of an enhanced recovery program is dealing with perioperative nutrition. It is well known that in patients who are malnourished, providing them with TPN for 7 to 10 days before surgery can reduce complications. Again, that's not news. But what may be news is that if you have patients with either elderly patients or patients with chronic disease like Crohn's, specific micronutrient, correction of specific micronutrient deficiencies can improve outcome as well. But I think the most important aspect of an ARIS program, and I'm going to show you a couple of slides about this, are changes in how we approach the patient that's coming to surgery in terms of feeding them before the operation. The traditional approach, at least in the United States, is nothing to eat or drink from the night before surgery. Well, it turns out that there's essentially no evidence in the literature to support that approach. This was a Cochrane review of 22 randomized trials that looked at various strategies for fasting before elective surgery. All of these were done on healthy adult populations without risk factors for aspiration. And they found a number of important things. First, there is no difference between gastric volume or acid in the stomach between all of the various regimens. And in fact, if you drank a glass of water an hour before surgery, you had a lower gastric volume compared to the patients who were fasted overnight. And so the recommendations of this Cochrane review were that they should have no solid food within 6 hours, but they can have liquids up to 90 to 120 minutes before operation. Now, I don't know if that's how you approach preoperative preparation, but it's dramatically different from how it's approached in the United States. This is another interesting systematic review looking at the administration of a load of glucose by mouth 2 to 4 hours before surgery compared to routine fasting. And what they found, they looked at length of stay, perioperative insulin resistance, complication rates, post-op nausea and vomiting. It didn't seem to matter in minor procedures or procedures that had a length of stay under 2 days. But if you look at major abdominal surgery, if you provide perioperative or preoperative glucose administration 2 to 4 hours before surgery, you see in this meta-analysis a statistically significant reduction in complication rate for patients who got the glucose. Or excuse me, this particular table is length of stay. Significant difference in length of stay, 1 day shorter on average, just by giving the patients a load of glucose before surgery. This is the slide that looks on complications. And you see that they did not find a significant difference in postoperative complication rate by giving the glucose before surgery. They did, however, have a shorter length of stay. 8 of the 10 studies in this meta-analysis showed a reduction in the usual postoperative insulin resistance that's seen in these patients, and the data were mixed in terms of postoperative nausea and vomiting. There's also high-level evidence that giving immune-modulating nutrition as opposed to a standard diet after GI surgery improves outcomes. This was a meta-analysis of 26 trials in 2,500 patients looking at complications, length of stay, and mortality. They did not find any difference in mortality in this meta-analysis. The types of immune-modulating nutrition, there are these 5 brands, if you will. This is the one that we use at USC. It's called Impact. And in this table, you see infectious complications on the top, other complications here, and length of hospital stay on the bottom. And you see, if before they come into the hospital, if you give them a week's worth of this immune modulating nutrition, they have statistically lower complication rates and a 1.5 day shorter length of stay. If you give it to them preoperative and postoperative, infectious complications are reduced, non-infectious complications are also reduced, and the length of stay is reduced by 2.7 days, with similar outcomes if you give this immune modulating nutrition postoperatively. So what can we do in the operative period to improve outcomes as part of this enhanced recovery approach? Well, prophylactic antibiotics, I don't really need to talk about that. We all know what the standard principles are there. But what you may not know is that it has been shown in a randomized controlled trial that if you give your patient 2 liters of oxygen for 48 hours after the operation, regardless of their saturation, if you give them a supplemental oxygen, they have a lower incidence of wound infections. So that's a part of a standard enhanced recovery program. Regional anesthesia is also part of the enhanced recovery program. It's very common these days, of course, to provide pain relief, but it's also been shown to reduce organ dysfunction as a result of the stress response. There are studies, for example, that have shown that if you give epidural local anesthetic before major abdominal surgery and you measure cortisol level, catecholamines, glucagon, these are all reduced compared to control patients. The postoperative hyperglycemia and insulin resistance is reduced, and nitrogen balance is improved. So it has not only pain relief effects, but it reduces the stress response to surgery, and this effect is maximum if you keep it going for 48 hours. It's interesting, though, that it doesn't have any impact on the acute inflammatory response to surgery, as all the acute phase proteins, IL-6, and cellular immunity are unchanged. And so this is a table that summarizes 5 different studies that have looked at the beneficial effects of regional anesthetic, and it turns out that giving a patient an epidural reduces infectious complications by 30%, pulmonary embolism and myocardial infarctions are reduced, other thromboembolic complications are reduced, blood loss is decreased, and the incidence of renal failure is reduced as well. So there is a very real benefit of regional anesthesia above and beyond the pain relief that it provides to your patient. And so it should be a part of the management of any patient in an enhanced recovery program. Minimally invasive surgery, of course, is desirable by patients because it's more comfortable, the recovery is a bit quicker. But it's also been shown, interestingly, that it's associated with a reduced inflammatory response. So unlike the regional anesthetic, which reduces the neurohormonal response, minimally invasive surgery reduces inflammation with lower levels of acute phase proteins, leukocytosis, and IL-6 following minimally invasive operations. And so that has led many investigators in this area to actually use epidural analgesia even with minimally invasive operations. It's removed at 24 or 48 hours, but the idea is it can protect against some of this stress response and all of the inflammatory mediators. Maintaining normal therapy is another important aspect of an enhanced recovery program. The typical operating room is 20 to 25 degrees centigrade, which is below the zone of thermoneutrality for a semi-clad patient. General anesthesia also alters the thermoregulatory set point, so the patient becomes poikilothermic and they lose body heat. Spinal and epidurals also cause cutaneous vasodilatation, so the cold room has a more dramatic effect. And it's been shown that a lower core temperature leads to an exaggerated stress response, increasing cortisol and catecholamine levels. It's been shown in randomized controlled trials that keeping a patient warm reduces wound infections, reduces blood loss in the surgery, decreases ventricular arrhythmias, and improves the negative nitrogen balance after surgery by 40%. So keeping your patient warm is also a critical step. Now, what about the postoperative period? Well, it's been shown that routine use of surgical drains does not reduce complications after a whole variety of common operations listed here. It's only been documented to be useful after a mastectomy. That's the only operation where a routine drain has been shown to be beneficial. Urinary catheters should be removed at 24 hours. Even if you're using an epidural catheter, as long as it's a low-dose opioid epidural, you can remove the Foley catheter in 24 hours. 30% will need the Foley put back in, but 70% can have it out, and therefore lower risk of urinary tract infection. And then routine use of nasogastric tubes after abdominal operations. Most surgeons like to leave an NG tube in to prevent vomiting and reduce pulmonary complications, but it's actually been shown in randomized, actually this is a meta-analysis, that paradoxically NG tubes seem to increase the risk of pulmonary infections. And that's shown in this meta-analysis. It was 37 clinical trials, 6,800 patients, 17 of them were randomized trials, and they looked at complications, length of stay, and need for tube reinsertion, and the best outcomes were reported when NG tubes were used selectively rather than routinely. And the numbers from the study are shown here. Overall complication rates significantly reduced. Pneumonia, very significantly reduced. Atelectasis, reduced. Time to oral feeding was increased. There was about 30% of patients who needed, or excuse me, 5% of patients who needed the NG tube placed in the selective group, but the vast majority of them, 95%, could recover just fine without a nasogastric tube and have fewer complications. Postoperative bed rest is obviously detrimental to recovery. We don't need to talk too much about that, other than to say that pain control has to be optimized to get the patient something about. And those pain control measures should minimize opioids. You should use epidurals, NSAIDs, and other systemic agents so that you can speed recovery without causing postoperative nausea and vomiting. Prevention of DVT and PE is one of the steps of an enhanced recovery program. There's a clear benefit to subcutaneous heparin. We don't have to talk about that. But what you may not know is that if you give an epidural with local anesthetic along with heparin, it's been shown to significantly reduce DVT and PE over subcutaneous heparin alone. Nobody really knows why that is, but that has been shown. Strategies to reduce post-op nausea and vomiting we'll come back to in a minute, but that's also one of the elements of an enhanced recovery program. I touched on this a moment ago, prevention of postoperative hypoxemia, so routinely giving your patients 2 to 4 liters of oxygen, especially at night for the first 2 to 4 days, not only improves wound healing and reduces infection, but it actually has been shown to reduce the frequency of myocardial ischemia, and it results in improved cognitive function, especially in the elderly. Early enteral nutrition postoperatively decreases gut permeability and reduces post-op infections compared to TPN or NPO. And this can be done safely even after bowel anastomosis based on this meta-analysis of about 15 randomized controlled trials. 14. They're shown here. This is a systematic review from the Cochrane database comparing early feeding versus traditional feeding, and they found that wound infections were the same. It didn't reduce wound infections. It didn't reduce abscesses, but notice it didn't increase them. The trend is toward fewer. Didn't change mortality, but it got the patients out of the hospital 1 day earlier on average and likely reduced costs. So, in the end of all of this review, then Kellett and his group reviewed all of the fast track or accelerated recovery programs that have been published in the 5 years since he originally proposed this approach, and those are summarized on this slide. And suffice it to say that when you use at least 4 of the elements that we just reviewed, improved outcomes were achieved in a whole variety: inguinal hernia repairs, cholecystectomies, lung resections, vascular procedures, etc. So it does seem like this works. Now, about 7 years later, as more data came available on recovery after surgery, Lassen and colleagues, who are also from the Netherlands, published this update looking at some recent modifications to enhance recovery programs. One of the new findings in terms of preoperative information is that if you clearly explain the recovery process, adherence to the pathway is improved and earlier discharge occurs, and that was published in 2004. And then if you sit down with your patients to give them clear targets for food intake, nutritional supplementation, and ambulation, the patients recover faster and get out of the hospital. Evidence also came available on preoperative bowel preparation with the recommendation that routine mechanical bowel prep before abdominal surgery is not beneficial. And that came from this British Journal of Surgery meta-analysis, 7 trials, almost 1,500 patients. They looked at leak rates, wound infections, septic complications, and other complications in patients with and without routine bowel prep. The information of the individual studies is shown here. What you see in this meta-analysis is that the anastomotic leak rate was actually lower if you didn't do a bowel prep than if you did. Oh, looks like I'm missing a slide. That's too bad. They also showed similar improvement in wound infections in patients who did not receive a routine bowel prep. So the current recommendations for enhanced recovery programs is to not use mechanical bowel prep before abdominal surgery. In terms of pre-anesthetic medications, they are now recommending that opioids and long-acting sedatives and hypnotics are not given as pre-op for anesthesia. They recommend you take the patient right into the room and put them to sleep, because patients can get up and walk faster, and they have earlier resumption of oral diet and can get out of the hospital sooner. Some further observations on DVT prophylaxis. There has been a meta-analysis conducted now that shows clearly that there's no difference between standard heparin and low molecular weight heparin in terms of DVT prophylaxis, or PE. It's also been shown that it is safe to use these when an epidural catheter is in place, as long as you hold the heparin for 12 hours before you insert or remove the epidural. They made further recommendations for the enhanced recovery programs regarding postoperative nausea and vomiting, and those are shown here. They've identified these 4 risk factors: females, non-smokers, history of motion sickness, and postoperative opiate use. If you have 2 of these, the recommendation is dexamethasone at induction and a serotonin antagonist when you wake up from anesthesia. If you have 3 of these, you need to modify the anesthesia using propofol and remifentanil with dexamethasone at induction and serotonin antagonist when you wake up. And so that's the recommended regimen for enhanced recovery with regard to post-op nausea and vomiting. In terms of laparoscopic procedures, they've identified in this meta-analysis clear evidence of improvement in outcome. There was 17 trials looking at a whole variety of outcomes here. There was no difference in anastomotic leak rate, 3 operations. But there was, with laparoscopic surgery, of course, it takes a little longer to do. Mortality rate was lower. Overall complication rates were lower. Wound complication rates were lower. Blood loss was 100 cc's lower, lower frequency of ileus, and get out of the hospital 2 days sooner. So the data have become established that minimally invasive surgery is the optimal approach and should be part of every ARIS program. 2 of the most interesting, at least to me, as a surgeon, modifications to enhanced recovery programs have to do with how we manage fluids in these patients. The standard approach, at least in our country, is these patients, the anesthesiologist assumes that the patient is dehydrated, which they probably are because they've been fasting for 12 hours. And so anytime the blood pressure drops because of anesthesia or whatever the case may be, they just turn up the fluids and run a bunch of fluids into the patient. Well, it turns out that's very detrimental to the patient. And the ARIS programs recommend avoiding fluid overload, using vasopressors judiciously instead, and in some cases, intraoperative monitoring of TEE to guide fluid administration. So this was a very interesting meta-analysis that was done, and it looked at all studies that reported complications based on the amount of fluid administered to the patient. They defined fluid balance as 1.75 to 2.75 liters for the whole day of surgery, for the first day. Anybody who got less than that or more than that was claimed out of balance. And when you looked at these studies, patients who were in fluid balance had significantly fewer complications than those patients who were in fluid imbalance during the perioperative period. Same thing for hospital stay, a significant reduction in length of stay in the hospital if the patients were maintained in fluid balance during the operation by anesthesia. Another approach, rather than just looking at the total volume of fluid, is to put a TEE probe in the patient during their major abdominal surgery and monitor their fluid balance and administer fluids on that basis. And that also seems to work. This was a meta-analysis of 4 studies, almost 400 patients. The individual studies are shown in this slide. When you look at postoperative complications, if you use a TEE to guide the fluid rather than just pouring fluid in, you get a significant reduction in postoperative complications, and you get a reduced length of stay, almost 2 days shorter length of stay on average if you use Doppler-guided fluid management as opposed to liberal fluids. So the next question after all of these proposals and revisions is, how well do these multi-modal enhanced recovery programs work? The first report that I'd like to draw your attention to is this meta-analysis of 6 randomized controlled trials using enhanced recovery programs compared to traditional care. To get into this meta-analysis, you had to have at least 4 of the elements of the ARIS program that we've talked about, but they ranged up to 12. On average, there was about 8. The outcome measures of this meta-analysis were length of stay, complications, readmission, and mortality. And they found no difference in readmission rates or mortality. So they're not getting the patients out of the hospital while they're still sick and having them come back. They were actually improving the patient's outcome. When you looked at hospital stay, it was on average 2.5 days shorter for open colorectal surgery when enhanced recovery programs were used. Complications were reduced almost in half. You see a significant reduction in the rate of overall complications for colorectal surgery. So what about applications outside of colorectal surgery? Well, fast-track programs came into thoracic surgery, my field of interest, in 1997. This was a case series, not a randomized controlled trial. The elements of the ARIS program were here: education, activity goals, epidural, early nutrition, and oxygen therapy. And they showed almost a 3-day reduction in length of stay with no change in cost, no difference in mortality or readmission rates. So you can at least get the patients out of the hospital sooner after lobectomy if you follow these fast-track programs. The group at Johns Hopkins, a year later, published similar findings. They looked at both lung and esophageal resections that were done there. They used patient education, early ambulation, activity goals, epidural, and early enteral nutrition as the elements of ARIS that they employed. They had a 4-day shorter hospital stay after esophagectomy and a 2-day shorter stay after lobectomy, lower costs for both with no increase in mortality. In lung cancer surgery, there's actually a randomized controlled trial. It's a small trial, but a randomized controlled trial looking at enhanced recovery programs versus conventional care. The elements of the ARIS program that they included are listed here. There's 7 of them. And what they found is, compared to conventional treatment, fast-track or ARIS programs resulted in a significant reduction in the incidence of pulmonary complications, with a trend toward reduction in other complications, reducing the frequency almost in half. And this benefit existed even for high-risk pulmonary resection patients with a low FEV1, again, a statistically significant reduction in the rate of overall complications when the ARIS program was used. In esophagectomy, fast-track programs have been used since Serfolio from Alabama published this report in 2004. The elements of the ARIS program are listed. 18% complication rate overall, which is remarkably low for an esophagectomy series, and their median hospital stay was 7 days. So very important, very encouraging early results, but this was again simply a case series. From Virginia Mason, Donald Lowe published this report in 2007, including these elements of enhanced recovery. They showed complications, mortality, and length of stay that were improved compared to historic controls, but again, not high-level evidence, but at least it's feasible to do. It has been shown in this comparative series that it reduces cost. Length of stay was shorter in this study as well. The rates of complications were not different. Mortality was the same, but they saved an average of €2,000 per patient by using an enhanced recovery program. What about gastric cancer? The group from Nottingham, UK used a ARIS pathway for both esophageal and gastric resections, as shown here. The elements of the ARIS program are listed there for you. The ARIS program reduced length of stay by 4 days. It also significantly reduced overall morbidity from 23% to 5%. It reduced, with no difference in mortality and readmission rates. So ARIS programs can improve recovery for gastrectomies for cancer as well. And that was shown, unlike esophagectomy, where it's only case series, it was actually shown in a randomized controlled trial to result in shorter length of stay, earlier return to bowel function, better quality of life scores, and about $2,000 cost savings associated with the enhanced recovery program. Interestingly, in gastric cancer, and this is the only situation where it's been studied outside of colorectal, is inflammatory mediators, IL-6, TNF-alpha, C-reactive protein, are all shown to be reduced when you use the ARIS program versus conventional care, and resting energy expenditure is also better in the patients who undergo enhanced recovery programs. There are studies in vascular surgery for both open and minimally invasive vascular surgery procedures showing shorter length of stay and fewer complications associated with ARIS programs. It's also been shown in several randomized controlled trials, 22 in fact, with 6,000 patients, that after joint replacement surgery, ARIS programs reduce complications, decrease length of stay by almost 3 days, and a lower overall cost, about a 50% reduction in cost. In liver surgery, enhanced recovery programs have been shown, or have been studied in 6 individual studies, only 2 of them randomized controlled trials to look at results after liver resection. The individual studies are shown here. These are the elements of the ARIS programs that were included in each of these studies. Anywhere between 8 and 12 individual elements were included. What they found in this meta-analysis is that in all of these studies, length of stay was shorter. There was no difference in morbidity, so getting them out of the hospital faster did not cost you anything in terms of morbidity or mortality or readmission rates. So although for major liver surgery it does not appear to reduce complications, it does speed recovery without causing readmissions. They've even come out with guidelines for Whipple procedures. The ARIS Society Working Group has done a literature review and consensus development specifically for the Whipple procedure. And in addition to all of the standard elements of an ARIS program, they have recommended preoperative biliary drainage should only be done selectively if the bilirubin is less than 250. Early drain removal should be done at 24 hours. You should not use somatostatin analogs, but all other elements of the ARIS program are recommended. At this point, we don't have any prospective data in Whipple procedures, but studies are ongoing in this area as well. So with all of that data that I reviewed, you'd have to ask, well, why don't we use enhanced recovery programs in all procedures? And the answer to that is because these are complex to implement. Change is hard in the healthcare system. Getting people to change behavior can sometimes be difficult. One way that you can go about this is to implement the enhanced recovery program through the ARIS care system. Now, it turns out that ARIS, Enhanced Recovery After Surgery, is a registered trademark of this group in the Netherlands and the ARIS Care Group. It's a formal perioperative system offered by the ARIS Society, which was founded in Sweden in 2010. It's been implemented so far in 40 centers throughout Europe. The first implementation outside of Europe was in Calgary, Alberta, Canada in 2013, and it's a 3-step system. The thing about the ARIS program is it costs money, and it takes a lot of money and a lot of time to implement the formal ARIS care system. And we'll talk a little bit about that. So the 3 elements of the ARIS system are the protocol, which I showed you before. You don't have to pay money to get this, because this stuff is all published, it's all available, and we've just reviewed most of it this evening. What you do have to pay for is the implementation program. It's a formal training system. It's customized to your hospital. They send someone out and they look at your hospital and they come up with a they develop a plan for training. It emphasizes team building skills, methods to implement change into healthcare processes, to be able to work through the resistance to making these changes. It requires a big commitment. You have to have 4 or 5 physicians and a bunch of nurses that will travel to be trained. It's 5 full days of training, 4 of them off-site, so you have to fly to Europe to be trained for this. And it requires commitment on an ongoing basis from surgery, anesthesia, intensive care, and the hospital ward, as well as quality representatives from your hospital. So So it really requires an institutional commitment if you're going to go into the formal ARIS system. It also comes with an interactive audit, so you have to enter data on all of the patients, then they can do analyses, report to you how you're doing, what your compliance rate is, what your length of stay and complications are. But this requires a, quote, team leader at each center who's going to enter all this data, and that takes at least 20 hours per week of effort on someone's part to do all of this. So, if you want to get some of these benefits for your patient, though, without joining the ARIS program, you can do what we're doing and what I'm trying to do at USC, which is to implement this program on a more grassroots level. And it's not that complicated, actually, if you break it down. There are elements highlighted here that the surgeon himself can take care of. All you have to do is change your practice a little bit and write different orders for your post-op patients. You can take the Foley catheter out anytime you want. You can feed your patient anytime you want. You can get them out of bed anytime you want. You can put a warmer on the patient in the operating room. All of these things are sort of low-hanging fruit, easy to accomplish by yourself. One that you can make a big dent in is preoperative counseling. You do need some help to really fully implement the enhanced recovery programs, pre-admission counseling, and I'll talk a little bit about how we approach that at USC. So when the patient comes in for their normal office visit, we of course assess their major comorbidities, all of the usual preoperative evaluation. We also educate them, as I mentioned before, about the benefits of abstinence from alcohol, even if they don't drink to excess. We have a discussion about postoperative pain and how it's going to be managed, and then at that time, we of course get the usual informed consent, which is obtained by the surgeon. Then the patients, 1 to 3 days before their operation, they come into a clinic that's called the Preoperative Assessment and Center for Education Clinic, or PACE. And all elective surgery patients come into this clinic. One of the reasons for the clinic is to do their preoperative testing, but we could do that anywhere. But the patients also will have a detailed discussion of the anesthetic plan that they're going to get. So they meet with an anesthesiologist, they talk about the anesthesia and what to expect, and they're educated about the recovery process, how long they're expected to be in the hospital, what the goals are for ambulation and diet, so that we take care of all of the perioperative or preoperative instruction component of an enhanced recovery program. Now, when you look at the rest of the components of the ARIS system, these are more challenging because they require participation from other people involved in the process. A lot of it has to do with anesthesia, but also it's impacted on the intensivist that might be taking care of your patients post-op, etc. Dealing with that problem or that challenge is a little more difficult because there's a lot of barriers to making change in healthcare systems. This is actually a Cochrane review that looks at change in the healthcare system and how to implement it, and they identified these 9 barriers. And all of these play a role in trying to implement an enhanced recovery program. For example, information management. If you're going to know whether the system works or doesn't work, you need IT from your hospital to be working with you to give you that information. You also, most electronic health records have standard order sets and protocols, and those things all have to be implemented as well. Clinical uncertainty and a sense of competence are big barriers to change in healthcare because physicians are comfortable doing things the way that they've always done it. So we have to educate anesthesia and ICU providers on this evidence that we've talked about tonight, and we have to give them that sense of confidence by holding their hand and working through this process while they gain experience. Other Other physicians involved may be concerned about liability. That's another barrier to change in healthcare, but if we give them the high-level evidence that we've talked about tonight, and recommendations from society guidelines, you can start to work through this process gradually. We've already talked about patient expectations, and those can be addressed through the PACE clinic. And then you need a lot of administrative support from your hospital to get through the financial problems and administrative constraints that inhibit change. So where do we stand at USC at present? In addition to all the things that I showed you that the surgeon can do on their own, we have made some progress. Working with our pain management team from anesthesia, we are now getting epidural catheters placed for all elective open procedures for perioperative pain management. We're still working one-on-one with them to try and get them to do intraoperative blockades for minimally invasive procedures for the reasons that I mentioned before. And then we're liberally using NSAIDs and non-narcotic medications instead of opioids for all their benefits. The perioperative fluid management has proven more challenging. The standard policy for 25, 30 or more years is that the patient is NPO after midnight. But as you saw, the recommendation should be no solids from 6 hours before surgery and liquids up until 2 hours. But we're really meeting a lot of resistance from anesthesia on that, mostly for fear of liability. Interestingly, the American Society of Anesthesiologists has exactly these recommendations. So hopefully with time we'll be able to encourage them to come on board. Fluid and carbohydrate loading 2 hours pre-op, that of course goes hand in hand with this. If they're not going to let you give your patient anything after midnight, they're certainly not going to let you give them 50 grams of carbohydrate. So this is still a work in progress. So to sort of summarize where we're at, in green are the things that we've accomplished. I'm sorry that doesn't show up well at all, but that we've made some progress with our anesthesia colleagues. These areas in yellow are the areas that we've made a little bit of progress, but we still have a ways to go. But you see, to get fully implemented into enhanced recovery programs, we still have some challenges ahead in implementing this change. So in summary, enhanced recovery programs, in regards to enhanced recovery programs after surgery, current quality of health care, at least in the United States, leaves a lot to be desired. It's not very systematic in its approach, especially to quality improvement. Many of our traditional approaches to trying to improve quality of care are unimodal in approach, which will take forever to make the progress we need. And we often ignore available level 1 evidence because the number of studies is just overwhelming. Enhanced recovery programs, which are multimodal in approach, have been shown to work, as I've shown you, in a variety of settings. And I would say that implementation is possible. You can take the first step as a surgeon by making some changes in your own practice. Then you can go after the low-hanging fruit, talking to your colleagues in anesthesia and critical care to make the implementation that doesn't require a lot of effort. But if you're going to fully implement the ARIS program, you really need an organizational or a hospital-wide commitment to this type of quality improvement approach, which I'm still working on. Thank you.
Well, thank you very much. Very impressive and wonderful lecture. So, especially I'm internal medicine, the education of patient with operative pain, it's very effective, very impressive. So, any other question from the floor?
Thank you very much for your very outstanding lecture. And I'd like to ask you about the practical method to implement ERAS. So the operation started at 7:30 in the morning.
Yes.
Yeah. And the patient comes just the day of the operation for open colectomy or...
Yes. So they will come into that PACE clinic, the preoperative assessment and education clinic, usually between 1 and 3 days beforehand. So that's where all of the education and discussion all happens. Mm-hmm. On the day of surgery, they arrive about an hour and a half before surgery to get their final preparations.
Just 1 hour? Or?
Yeah, because all of the rest of the preoperative testing and everything else has been done, 1 or 3 days before.
Mm-hmm. So the patient who lived outside of Los Angeles, mm-hmm. They stay in the hotels near the...
Yes, some of them do. Yeah, Los Angeles is a big area, and we have patients even from outside of Los Angeles that come in. Some of them will stay in a nearby hotel, but some of them will get up at 2 o'clock in the morning and get in their car and drive to the hospital. So it's kind of a mixture.
Thank you. アメリカの手術というのは大体7時半に出頭なんですね。で、大体回復の大調節場とかでも全部入院する手術の日に入院しますからですね。何時に患者さんは来るのかという話を聞いたんですけども、大体1時間から2時間ぐらい前に来るということで、その代わりいわゆるその術前のですね、すべての、処置とか教育とかですね、するために大体術前3日前から1日前ぐらいまで何度もそのクリニックにですね、ペースって言ってましたけど、プリオペラティブクリニックですね、に来て、そこで全部すべきことは終わってしまうということです。で、ロサンゼルス以外に住んでる人とか、ロサンゼルスでも遠い人とかいうのは近くのホテルに泊まる人もいるということです。And when did you take informed consent, and who takes the informed consent from the patient?
For most of the patients, we will do, for major surgery, we will do the informed consent when they're in the clinic seeing the surgeon. So when they're in the office to see me. For some of the more minor procedures, they may get it in the PACE clinic when they come in, and then one of our residents will actually get the consent form. That's usually because, for example, if I have a patient who let's say I have a patient with a stricture after an esophagectomy, and I'm going to take them to the operating room for a dilation. I don't need to make them drive from their home to see me in the office to get the informed consent when they've had it done before and they just need to have it done again. So for relatively minor procedures that are repeated type things, we don't do it. But for any major surgery, we do it in our office when we see the patient.
Operator do the informed consent.
Yes.
Operator. 誰がインフォームドコンセントをするのかという話をしましたけど、 通常のメジャーサージャリーではやはり10社がするということですね。マイナーサージャリー、おそらくラパポレとかそういった類のものはレジデントがペイスクリニックという、それこそ手術の1日前とか2日前に来た時にすることですね。メジャーサージャリーであれば術前に外来に来た時に10社がするということです。Thank you very much.
So any question? I think, oh yeah, Dr. Morita.
Thank you for your exciting presentation, Dr. Hagen. I'm Keisuke Morita, attending Dr. Gastroenterological Department. ERAS program is very interesting for me and for my patients. But in Japan, sometimes non-evidence convention, which we learned when we are resident, is used. What should we do to start ERAS program at first in the hospital?
Yeah, well, that's that is a challenge at many hospitals because we have a saying, old habits die hard. It's hard for people to make changes to things that they're accustomed to. My only advice is to just start one by one implementing things that we know that there's high-level evidence for and that aren't that difficult to accomplish. And then it's just like, starting a wheel in motion. It's harder at first, but once it gets going, it gets easier and easier to pick up speed. And that's the best advice I can give you. Unless everybody gets together and says, we're all in this together, we're going to make this happen, and you have a whole institution-wide commitment to it, that's the only way you can do it, is just one by one, implement the principles, and build momentum from there.
And is it effective for not doing all of the ERAS program, undergoing protocol, but doing only a part of it, like oxygen taking after surgery for 2-3 days?
Yeah, the difference between just looking at any one of these things as opposed to multiple together is that, well, let's just, to give an example, if you did one intervention and it reduced your complication rate by 10%, unless you did a couple hundred of those procedures, it would be hard for you to notice that 10% improvement. So you put a lot of effort in and you don't see the benefits for a long time until you do a lot. But if you do two things, 10% each, then it starts to add up. And you do three things and it gets even more benefit. Then you will see the results sooner and it becomes easier to get people excited about and implementing these changes. Most of the elements of an ERAS program on their own will work because that's where all of the studies that I showed, each of those studies was, until the end when we were summarizing the ERAS, but each of those things, no NG tube, no bowel prep, giving glucose, each of those were studies looking at one individual element and they work. The problem is the studies had thousands of patients in it to prove it. So it will take you a long time to notice the difference if you go one by one. But if you put them all together, you get all of the accumulated benefits and you see the results quicker, and it makes it easier to get people on board with the change.
Thank you. I tried one by one.
And also go to the Sweden.
Yeah.
You will. Any question? So we very appreciate Professor Hagen, your excellent lecture and great contribute to us. So thank you very much.
この時には